Okay, so as Sonia stated, today we're going to look at some diagnostic tests that patients go through and just give you a bit more of understanding as to what they are and why they get done. These might have been done either at the diagnosis stage. Throughout your treatment, you'll have these as well. And if you get to a stage where you have no evidence of disease, then you'll have a surveillance program. So we'll talk about that as well. I too want to acknowledge that I am currently on Wurundjeri Woiwurrung land, and I'm originally from the land of the Wiradjuri people in New South Wales. I pay respects to all traditional owners of country throughout Australia and recognise their continuing connection to land, sea and community. So today we'll talk about some imaging tests. So there's so when we talk about tests, we'll have imaging tests where pictures are taken, and we'll also have blood tests where your blood's taken. So imaging tests include abdominal ultrasounds, endoscopic ultrasounds, CT scans, MRIs, or PET scans. You may have had all of these, you may have had a couple of these, or any combination of them. So if we look at abdominal ultrasounds first, an abdominal ultrasound is a imaging test that uses sound waves to see inside your abdomen. So the probe there will be pulsating sound waves in there, and then that will be bouncing back and giving the radiologist or the sonographer an image of that area. So this may be actually one of the first tests that people go to have after they've been to their GP complaining of signs and symptoms of upper GI cancer. So this can kind of help determine the cause of stomach pain. It can also check for things like kidney stones, liver disease, and tumours if they're present. Going off to have an abdominal ultrasound, as you can see here, it goes onto your abdomen, and this is where the rib cage is. So this is where the liver is on this gentleman, and where she's currently got that probe there, that's where your stomach is. And in the middle here around the belly button is where the small intestines are. Okay, large intestine comes up here and does like a big square as well. So they have a pretty good picture of things that are inside your tummy. Some of the restrictions that abdominal ultrasound have is if you've got a bigger tummy, the sound waves on the end of the probe have to actually go through lots of layers. So there's your skin layer, any kind of visceral fat, muscle layers, as well as kind of any other organs. So if you remember seeing a picture of an upper GI, your upper GI organs, for example, the stomach lies closer to the skin under this probe here. However, the pancreas lies underneath the stomach. So in order to get imaging of a pancreas, you'd have to actually try and get those sound waves to go not only through the skin, the fat and the muscle, but also through the stomach. So it does have its limitations. Over on this side, they do get some good visualization of the liver. However, again, under that liver, tucked away under the liver, is your gallbladder and your bile ducts. So depending on how well they can see, how well they can push down. So if you're experiencing pain in your abdomen, it also means that they may not be able to probe as hard and get some good imaging. It also is determined by how well the sonographer is as well and what they're looking for. So we always encourage people to get a really good referral from their GP that states specifically what they're actually, what the patient is actually complaining of, what kind of signs and symptoms they have, but also what the GP is like looking for. So a lot of the time with our patients, initially an abdominal ultrasound might be done because GPs are generalists. So if you're going to your GP with symptoms, it might be reflux, might be abdominal pain, it might be some back pain. They might be doing what we call picking off the lower fruit. Okay, so an abdominal ultrasound would be done initially, and they might be looking for very common things like gallstones, which is where stones are actually in your gallbladder and they block the bile duct. They might be looking for kidney stones, which is very, very common as well. And they might also, depending on what gender you are, if you have female organs, they might also be looking at like things like your ovaries and that kind of stuff as well. So it is kind of a thing where they're just going on a searching, they're going for a bit of a search. So abdominal ultrasound is a fantastic diagnostic tool, and it can also be used throughout your cancer trajectory as well, in the fact that if you need to go and have a biopsy done, you might have had a biopsy done via an ultrasound. Again, they'll put the probe over the area that needs to be biopsied so that they can actually see where, when they put the needle in, if it's going in the right area, so that when they suck those cells out to send it off to pathology, they've hit the right mark. So abdominal ultrasound can be used prior to diagnosis to send back to the GP to give them a bit of an idea as to what to send the patient for next, but also can be done in that staging aspect of your cancer journey, where we need to get a biopsy done, and abdominal ultrasound is a very good way of doing that. The other imaging test that you may undergo is something called an endoscopic ultrasound. Now, endoscopic ultrasound is a combination of a gastroscopy and an abdominal ultrasound. So it's essentially, you might also, have been sent off to have something called a gastroscopy. Gastroscopy is where a probe, a thin flexible tube or an endoscope is actually inserted down into your gastrointestinal tract, into your stomach, and it can take pictures and biopsies. But the endoscopic ultrasound is slightly different, because at the end of this probe here, it actually has an ultrasound probe that can send sound waves through the stomach into the surrounding tissues and organs as well. So it creates this image, and it can also show the endoscopist images of the lining and the walls of the organ. So just say, for example, you have an esophageal cancer or something up in your esophagus that's been detected, then they'll use the probe to see how thick it is away from the actual tube, so how far out it goes. Same too with the stomach. It'll determine how far the tumour or the growth goes through the stomach wall. If you have a pancreatic tumour or mass, then the ultrasound probe will sit here, and then the needle will actually come out and go through the back of the stomach into the area of the pancreas where the tumour is. If you have a gallbladder or bile duct tumour, so over here, what will happen is that probe will come down a little bit further, and then it will kind of put a little needle out and go and biopsy the area in there. So it's a fantastic way of staging cancer, as well as getting biopsies. So if the biopsies are unable to be gotten from the abdominal ultrasound, where they put the probe on top of your tummy, they can actually put the probe down, the ultrasound probe down your throat into your stomach, and try and get biopsies from inside the stomach into whichever organ you may have had a mass. It can also do, as I said, it can tell them how thick, and you can also do some sizing of things. So they'll be able to determine it's, 27 millimeters by, 15 millimeters, for example. Patients put under sedation for this procedure. So it's a day procedure in a hospital. You wouldn't expect to stay overnight unless there was any complicating factors. But again, it's about a 30 to 40 minute procedure where you are sedated, just so you don't have a general anaesthetic, because you have to go through your mouth, so you need an airway. So you're breathing actually on your own, and the endoscopic ultrasound probe just goes down like a gastroscopy would. So CT scan is probably one of the most utilised scans in cancer care. And CT just basically stands for computerised tomography. And tomography is just a fancy word for finding like the layout. So it's used a lot in geography. So it's actually an X-ray, and it's taking X-rays as a slice through your body, and then it comes up with a big image at the end. So a CT scan, as I said, it uses X-rays to create that detailed three-dimensional image from inside your body. It can help figure out where exactly cancer is. If you've been diagnosed with a mass of some description, then what it can do is it can actually give the radiographer an idea of the type of mass that is. So masses will look different. If it's a cyst, it will look very different to a tumour. Okay, so what they'll be seeing is, you know, the lighter area might have a lot of fluid, whereas the darker area might be really dense, a dense tissue area. So they'll be able to determine and give their report back to the surgical team or the multidisciplinary team or the oncologist as to what the findings are. But usually they'll just go through slice by slice through your body like that and have a look at all these different areas. So it will figure out where the cancer is. It'll also determine its size. So again, they'll be able to determine to the millimetre how big the tumour or the mass is. And it then will also determine whether or not you need to undergo any other further scans. Sometimes CT scans aren't great. There may be the need to then go on and have a more detailed CT scan, and that's perfectly normal too. So again, really hard to get the imaging perfectly correct, and it might be a positional thing depending on where the abnormality in your body is. They might not be able to get a very good view. So you might need to come and have a different type of CT scan where they change up a few of the details. So it's all very technical, but essentially what they're doing is a more higher quality scan, CT scan. So run-of-the-mill CT scan, very, very used often. It can also be used throughout the journey. So again, diagnostically, it's a very good diagnostic tool, but then throughout your cancer, so if you go on to have what we call neoadjuvant chemotherapy, that's just a fancy word for chemotherapy before you have surgery. So if you have a CT image taken at the start, you might then go on and do chemotherapy for 2 rounds, 3 rounds, 4 rounds, whatever your team decides. And then they'll do another CT scan and compare and contrast. So they'll be able to see whether or not the tumour has actually started to shrink. If that's the case, it's a little bit like a choose your own adventure book from then on in. So it's like, if it's shrunk, we're going to plan this. If it's the same, we're going to do this. If it's grown, we're going to do this. And that might be, if it's shrunk, continue for another 3 rounds. If it's the same, hit it harder, or maybe even proceed to surgery and see if they can do surgery. If it's grown, change the chemotherapy regime. It's not working. So that's why they do the CT scans. It's often done 3 monthly or as determined by your team. Again, it might be a little bit different because if you're having treatment, they might want to see after a couple of rounds whether or not the treatment's working, and then you can get into a more rhythmical pattern as to having that CT scan every 3 months. So we work out how well the treatment is working. We also, if we get to a stage where you need to have a break from chemotherapy, and that's okay, some people do, some people may not be either coping with the chemotherapy side effects and need to have a bit of a break to give their body a rest, or they might have got their tumour to an inactive stage where it's not actually growing. And again, we can give your body a rest and you can build your body back up again before going back onto it. We utilise the CT scan just to see what's happening in those periods of downtime before we go back into a treatment. So it is utilised as a diagnostic tool as well as a surveillance tool as well. The surveillance timing will change. So the surveillance timing will be a as often as your team require, 3 monthly, then it might be 6 monthly, and then you might actually get out to 12 monthly. So it's really important that when you're communicating to your team, it's that clear communication about when is my next CT scan booked? When am I due? How often will I have it for 3 months? When will I go to 6 monthly? So, and that's kind of driven by you, the patient, especially if you're going into, well, either public or private. The thing is that you're the one or your carer are the ones that are driving your care and keeping an eye on when you're having tests and things. So having like a little bit of a diary or a notebook where you can write in your dates. You are allowed to ask for your CT scan results as well. So having a copy of your CT scan result is very helpful to just have like a printout. It doesn't necessarily mean that you'll understand it. That's okay. It is a lot of gobbledygook on there. But if you collate them in like a little folder or something, what that means is if at any point you need to go to hospital and it's a different hospital to where you're being treated, it might be quicker and easier for the doctors in emergency to quickly have an overview of what's happening and stuff, and they'll be able to see when your last CT scan was. So us at Pancare, like we would encourage you to try and get those results as if you can. If not, at least have knowledge of where those CT scans are done. So if, for example, you have them privately, it might be like a IMED or a RADOS, or might have any number of names, as long as you know where you've had them done, so that if anything is to happen and you become unwell, then the doctors are able to access those results and just see where you're kind of at, because you may not be able to actually tell them in that time. It might be 3 o'clock in the morning and you might be in hospital with a chest infection, like something totally unrelated. So really important that you advocate and be a little bit organised if you can by getting the results of those. So the CT scan is just a massive big machine. They all look pretty similar, actually. They're just big round donuts, and the body slides in on a very uncomfortable bed there. So it's just like a metal bed that you lie on. It's very uncomfortable. It can be a little bit unnerving, particularly if you have any kind of issues in being in enclosed spaces. But the team in radiology are very, very good. Please let them know if you are feeling anxious or you're not feeling well, and they'll be able to kind of talk to you throughout that, as well as kind of check in on you as well. Can be noisy. However, the noisiest scan is probably the MRI scan. So an MRI scan is another scan that you may have. It's a magnetic resonance imaging. So instead of using X-ray like the CT scan does, it actually uses magnetic fields and radio waves, again, to get that kind of cross-section of your body. So it's using these big, powerful magnets. So the magnets rotate in this big dome, so the big donut, and it's very, very noisy. So it can be quite unnerving. Again, if you are feeling anxious, please let the team know. They can often do things like have music playing in headphones and that kind of thing. So keep that in mind when you're having an MRI. You don't necessarily need to experience it so badly. You can try and make the experience a little bit better for yourself as well. In some cases, they might also inject dye. So there will be the need probably in all these scans actually just to have an IV bung put in. They may not necessarily access your port or your PIC. So they might just put like a little IV bung in your hand. And then they'll just take it out at the end of the day. All these scans usually are procedures that you're in hospital for a couple of hours for. So you shouldn't need to be in hospital unless you're acutely unwell and they keep you in there. So the MRI is usually used for, it'll find the tumour, so similar to the CT scan, but if the CT scan doesn't quite show things up properly, you might go on to have an MRI scan. but it also measures the blood flow in and around those areas. So the abdominal cavity has a lot of big blood vessels. It's not just kind of your heart that has the big blood vessels. The blood vessels go from your heart down through your abdomen so that it actually can get blood flowing to your legs and your feet. And also comes up to your arms as well. So big blood vessels inside the abdominal cavity. So we need to kind of see where the tumour or the mass or the abnormality is in relation to all of those components that have blood flow go through them. So your blood vessels are your veins, and if you're going on to have like surgery, or you're going on to have biopsies and that, we really do want to know how close in relation to these blood vessels, the arteries and the veins, these things are, because we don't want to cause a bleed. So we don't want any intra-abdominal or inside your abdomen big bleeds. That's the last thing we want. It can also see whether or not the tumour has spread. So again, it's used in what we call the staging aspect of diagnosis. And sometimes it can also be used at a later point, particularly if you're having chemotherapy prior to surgery, again, to see whether or not the tumour has shrunk, and whether or not the tumour has shrunk away from blood vessels. So that's really, really important that we try and determine how safe it is to proceed with surgery, given that there's a lot of big blood vessels in the abdominal cavity. Another scan that's sometimes done, sometimes not done. So sometimes people will have a PET scan as a baseline. A PET scan stands for positive emission tomography. And basically what it does is it's going to reveal the metabolic process of your tissues and organs. So all cells, all organs, everything in our body uses energy. Metabolic is your energy rate. So we all need energy in all of our cells. So they need food and stuff like that. So a PET scan uses a radioactive drug, what we call a tracer. And usually it's given with an infusion. So again, you will have that cannula put in your hand and they'll inject it into you. So the tracer, which is radioactive, is combined with a glucose solution. So you'll have an IV that has a sugary bag put up. And what will happen is areas that use a lot of energy need sugar. So if you have something like a tumour in your body, tumours use a lot of energy. They need a lot of energy. And that's why we see people, when they're being diagnosed with cancer, they might already started to lose weight. And that's because the tumour's using the energy. So you're not eating enough energy for the energy that your body is using. So the tumour within the body uses a lot of energy. And what it will do is it will draw the glucose to it. So when you're having a PET scan, you're drawing that glucose to your tumour because it uses the energy, but you're also drawing the radioactive tracer that's attached to the glucose. So that's why it shows up on a picture, an image. So if you see here, this is an image of, this is actually lymphoma. I didn't get a upper GI test, but if you can see these areas of black, that's where the glucose has gone to, and the glucose has taken the tracer with it. And that's why all these spots have shown up as black. So as you can see here, this is the patient's bladder. So if you're having an IV, you know, when you have an IV and like if you have like a litre of IV, you'd need to go to the toilet. That's because it's gone through your system, filtered through your kidneys, and it's come down to your bladder. So you can actually see the tracer there in the bladder. That's not unusual. You'll see that. You'll often also see other things show up. So in this person, they don't, but what you might see is a little bit of uptake in the arms up here, and it could be that they've got some arthritis in their arms, like their shoulders. And that could also show up in like your hip bones and your knee bones if you've got arthritis or inflammation in them. So again, areas of inflammation are using a lot of energy in order to get better. So to fix the area that's broken. So if you have arthritis and inflammation, there's going to be a hive of activity trying to get that back under control and fix those cells. So they'll draw the glucose as well. So sometimes you'll hear physicians say, oh, it lit up like a Christmas tree. It doesn't necessarily mean that cancer is everywhere in your body. It can be because, you have arthritis, or you have inflammation somewhere, or you have a full bladder. So yeah, they will be these things here because it's lymphoma, it's in the lymph nodes, but it's a pretty good, it shows a really good kind of where the lymph nodes are around this liver here. So that's the shape of the liver, and that's the lymph nodes and the esophagus there. So the lymph nodes next to the esophagus. So as I said, the PET scan will detect abnormal metabolism of the tracer. So it's going to the areas where it's needed. And in conjunction with the CT scan and the MRI, will give your team, the MDT, your surgeon, your oncologist, a really good idea of where the cancer is, and what the plan is from there. The important thing is that after you've had these tests as well, if you have had anything put into your veins, when you're going home, try and drink as much as you can, so that you can kind of get all of the stuff out of your body. So we want you to metabolize that, go home and wee it out, because that's how we get our medication out of our bodies. We actually wee it out. So once it's metabolized through your system, going home and really staying hydrated, so that you can excrete it out of your body, or you can wee it out of your body. Another point I just want to go back to the MRI scan. The safety around MRIs, because it's got a magnetic field, if you have anything that's metallic in your body, you won't be offered an MRI. Okay, so if you have a pacemaker, if you have a knee replacement, a hip replacement, if you've got dental implants that are metallic, if you have a cochlear implant in your ear, all these things have metal in them. And this is one of the strongest magnets that we possibly have, that we put near humans anyway. And it will actually pull the metal out of your body. So if you have any metal in your body, you will not be offered an MRI scan. So if you're thinking, oh, I didn't have an MRI scan, just have a think, do I have any metal in my body? And sometimes it's not always used as well. So yeah, that's just a safety aspect with an MRI. If you have any metal, you won't be having one. PET scan, again, it's not usually done a lot of the time. It can sometimes be done to show up things that the CT and the MRI don't show. So sometimes it can be, if you've gone a long period where you've been no evidence of disease, so your cancer is in a stable state, it's not active, you might be feeling off, have pain, like concerned, oh, I think my cancer might be back. Sometimes if you have a CT and it doesn't show up, MRI, it doesn't show up. Sometimes on the PET scan, it will actually show up, because it shows up things a little bit earlier than a CT and an MRI. Because a CT and an MRI, if you imagine, you kind of have to have probably the size of your fingernail in cells. So you have to have a little bit there for it to see. Whereas with the PET scan, because it's using the metabolism of those cells, so it's banking on the fact that they're going to use glucose and it's going to take the tracer there, it's going to show up a little bit sooner. So it can actually show up little spots, and they'd just be like little light grey spots. And that's when the team will then be able to determine what to do from there. So blood tests, this is something that a lot of patients will have on the weekly. And there are many blood tests that you will undergo. It may not necessarily mean that, they're taking out 10 vials. It might just be that you're having a couple of vials taken out, and they can do multiple tests in those vials. So things like a full blood count, urea and electrolytes, these are just their fancy names, liver function tests, blood glucose, CRP, cross-match group and save. You might have cancer, tumour markers done. Coagulation, it just means how thick or thin your blood is. You might have something called a blood culture. You might have genetic testing via blood. You might have hepatitis screening. Particularly, you'll want to know about your white cell count and your red cell count, and your hemoglobin and your platelets. So I'm not going to go through all of these tests because they are quite specific to the person. For example, not everyone will have genetic testing. You will only have a blood culture if you have infection in your body. Cross-match group and save, you will only have, that's the test that we do to determine what blood type you are if you need to have a blood infusion. So if you need to have a transfusion of blood, a bag of blood put up because your red cell count's too low, they'll actually cross-match group and save. So they'll try and get the closest blood to you. So you may not have all of these, but I think it's important that we look at your red blood cells. So red blood cells are the main, red blood cells are carry oxygen around in your blood. Okay, they also then carry carbon dioxide back to the lungs so that it can be exchanged for oxygen. So when you're having cancer treatment, particularly chemotherapy, so if we think about the aim of chemotherapy, so chemotherapy in a nutshell is chemotherapy will attack fast growing cells. So red blood cells are fast growing cells that will be attacked by chemotherapy. So your team will want to keep an eye on your red blood cells because red blood cells carry oxygen around your body. Okay, so if you don't have enough, you're not going to be carrying enough oxygen around. So it's fairly common for cancer patients to develop something called anemia. So you might hear your doctor say, oh, you're a bit anemic. That means that your red blood cells are low. So the way that you would recognize that you have anemia or you have low red blood cells is that you might be feeling more tired. You might be a little bit weak. You might have a change in your color of your skin. You might feel a little bit short of breath, and you might have some dizziness or lightheadedness or confusion. So, I mean, if you look at like your pale skin, the reason why we're kind of pink is because your red blood cells are going to the blood vessels just under your skin. So if you don't have enough of those red blood cells, then you're going to look paler. Often if you pull your eye down and it's nice and pink in the eye, I hope mine's nice and pink anyway. So if you pull your eyelid down, just looking in the mirror, if that's not nice and pink, it might mean that you are a little bit anemic as well. So if you're pale, if you pull your eyelid down and that's not pink, it's just like a really light pink, you might be a little bit anemic. So there you kind of pinpoint. If you're feeling really tired and short of breath, we feel short of breath because we don't have the oxygen to go to our muscles. So if you're walking to go get the mail, you might be a little bit puffed out, and that's because your body is trying to get oxygen in to go to your muscles, like the muscles in your legs, to walk out to the mailbox. So that's why you feel short of breath, because you're trying to get that oxygen in. So your body's like overcompensating to try and get that extra oxygen in to try and get your muscles moving. And that's also why you feel tired and weak, because you just don't have that oxygen. Sometimes people do get a little bit dizzy and lightheaded. So if you stand up too quickly from a chair, you might get the old ooh, and that's because your body hasn't had a chance to take extra oxygen up that's needed. So really important that if you are anemic or you have low red blood cells, you're thinking about your safety. So when we think about your safety, we're thinking about things like not getting up too fast from a chair in case you get lightheaded and dizzy. If you're finding that you are a little bit wobbly on your feet, utilising things that can help you stand and walk. So if you need to use a walking stick while you're undertaking chemotherapy, don't take it as a kind of, oh, well, my body's failing me. Take it as this is going to keep me safe. And these are the reasons why I need to utilize some kind of a walking aid. It's to keep you safe, it's to keep you active, and hopefully, if your red blood cells kick back in again, so you might need to take a break from chemotherapy for that to do. So as I said, they're a fast growing cell, so they'll actually kick back in quite quickly and can regenerate within a couple of weeks. So you won't be feeling like that for very long. If it gets too low, so when they do your hemoglobin, if it gets too low, they may actually do a group screen and hold, find an adequate blood to transfuse you with and transfuse you. That's pretty normal in cancer care, having transfusions. Doesn't mean you've failed. So another type of blood cell is your white blood cells. So white blood cells are part of your body's immune system. So they help us fight infection. So anytime what we call an invader comes into our body, the white blood cells will go and attack that and kill it so that it doesn't create something in our body like a virus or a infection or something like that. So just say we're out and someone coughs near me, it goes up into my nostrils, up into my sinus tract and sits there, and then it starts to multiply and grow. It might also go down into my lungs, multiply and grow. White blood cells will come out and go, you're an invader, I'm going to kill you. So if you don't have enough of those, then you will be highly susceptible to infections. So that's what we call neutropenia. So it's fairly common for people with cancer to have neutropenia. And it's just when you don't have enough of the white blood cells. Again, if we go back to your cancer treatment, if you're having chemotherapy, chemotherapy will attack fast-growing cells. White blood cells are another fast-growing cell. So that's why the white blood cells go down. So some symptoms of having low white blood cells might be that you are feeling a little bit fatigued, and you might have an infection, and then that infection might keep coming back. So you might go onto antibiotics and then think, yep, I'm okay, but then it's still there. And will flare back up again. So it is quite common for patients to get things like lung infections, bladder infections, and that's why if you go in to your care provider, you might have, when you come out of starting your treatment, you'll be given a guide as to when to present to emergency, and it will say things like, if your temperature is greater than 38 degrees Celsius, go to emergency. And that's because the white blood cells are low, and you won't have the ability to fight that infection unless we kind of assess you, find out where the infection is, and give you appropriate antibiotics. White blood cells will also come back. As I said, they're fast-growing cells. So when you have a break from chemotherapy, often this is why you have that kind of week off in your chemotherapy regime, just to try and get your bloods a bit of a chance to bounce back. If you have a break from chemotherapy at any point, then the white blood cells will quickly bounce back. Okay, so you won't be neutropenic. The only other big thing that people ask us about a lot of the time is cancer tumour markers. Now, cancer tumour markers won't be done for everyone, so just be mindful of that. You might not know what yours even are. So the tests are generally not used as a screening or a diagnostic test. And that's because the markers can go up if you have other things going on in your body. So, for example, tumour markers might go up if you have pancreatitis. Tumour markers might go up if you have gallstone, like a gallstone attack. So depending on when you're taking the blood test, it really doesn't tell us too much about, well, we shouldn't be using it as a diagnostic tool or a screening tool, for one, because it can be varied for different things in your body. What we can do, though, is take it throughout your treatment And that will give us a better idea. So it's not a one-off test that you should go, oh, mine says 100. Oh my goodness, you know, that's awful. What we do is we actually go from the first blood test that you have for your cancer tumor markers, and it might be 570, and then it might be 680, and then it might be 320, 100, 50, 30. So what we're actually doing is we're actually looking for a trend, a downward trend. It's normal for it to go up. It'll drop dramatically if you have the cancer removed via surgery. But often what we're doing is we're actually looking for that downward trend, and that's over months. It's not over a few weeks, it's over months. And then we'll get like a little plateau, and that's when the care team will be like, okay, this is working, we'll just keep going, just keep going, just keep going. Might even give you a break. And then what they'll do is when you have your cancer tumor, they might start to elevate again, and then they'll need to probably send you off for a CT and see what's going on. So it's used as a like as a long-term kind of trajectory thing. So we want to see the pattern. We don't want to have one-offs. We want to take it over the course of your treatment just to see what's happening, so that it can help us determine if it's working, the treatment's working or not. Often you'll have a CA 125 for upper GI cancers. So particularly if you have any peritoneal involvement, so you might have one of these in stomach cancer, CA 125, ovarian cancer, it goes up in, and the other one that's quite common in our cancers is the CA 19.9, which is used for other gastro malignancies and pancreatic malignancies. So this is the most used one, and this, depending on the type of your cancer, is another one that's utilised as well in a few of our cancers. Again, trend is what we're looking for. Yeah, so they're kind of your top 10, if you like, of tests that you will undergo. So if anyone has any questions, then please speak now.